Hello, I'm Dr. Marwan Sabbagh, a neurologist, Director of Translation Research at the Cleveland Clinic Lou Ruvo Center for Brain Health in Las Vegas, Nevada, and spend the entirety of my time and career taking care of people with Alzheimer's and other dementias and doing research. So Lewy body dementia is, I think, the easiest way to look at it is it's a hybrid disease of a little bit of Alzheimer's pathology, a little bit of Parkinson's pathology, but clinically it is distinct and it is not truly one or the other, but a little bit of both. It is not rare. If you look at the data in most Western countries, Lewy body dementia is the #2 most common dementia after Alzheimer's. Some people say it's vascular dementia, but our data, at least in the United States, suggests that Lewy body dementia is common and is the most prevalent after Alzheimer's disease. The reason this is important is that Lewy body dementia is characterized by the aggregation of alpha-synuclein into the Lewy bodies, which was first described to be sequestered in the substantia nigra in Parkinson's disease. But the differentiating feature pathologically, at least from Kosaka, is that Lewy bodies in Parkinson's disease were sequestered into the substantia nigra pars compacta, but in the Lewy body dementia or Lewy body disease, it was the Lewy bodies were seen throughout the cortex. The third thing, of course, is that we think there's clinical syndromes that clinically define the phenotype of Lewy body dementia. And so the clinical diagnostic accuracy in the past has been low, around 50%. But with the newer criteria and using the screening tools like the Lewy body clinical rating scale, I think the specificity and sensitivity of clinical diagnosis has gone up and has gotten better. The third thing is that we see is that the nomenclature is confusing, and the confusion is around, is it Lewy body disease or Lewy body dementia? And is it with Alzheimer pathology? Is it without Alzheimer pathology? We know that you could be DLBD, meaning diffuse Lewy body disease, which implies that you have neocortical Lewy bodies without plaques and tangles. Or you could have LBV, Lewy body variant, which could be neocortical Lewy bodies with plaques and tangles. The questions have been over the consensus criteria of the first, second, third, fourth, and fifth convening criteria are congresses are, is it all one disease, the DLBD and LBV, or are they separate diseases? For the most part, we would just call them Lewy body dementias. Next is we know that there are very few effective treatments and there are no directed treatments for Lewy body dementia. And so we would say that we would use symptomatic treatments as we would cholinesterase inhibitors to treat some of their features. And we're using the neuroleptics and other antipsychotics to treat some of their neuropsychiatric features. And importantly, there are drugs like pimavanserin that are being looked at as potential treatments for the neuropsychiatric features. I like to say that Lewy body dementia is very, very common and nobody's ever heard of it. So I spend a lot of times when I see my patients with Lewy body, which is a lot, I would say I see at least 3 to 5 a week, spending time describing and explaining what Lewy body dementia is. So the criteria is very important that this audience understands what the criteria are. The core features are progressive cognitive decline with an amnestic component. Fluctuating cognition is critical. That is to say that better, worse, better, worse. And they have to have well-described visual hallucinations. They tend to act out dreams. And when they have Parkinsonism, it tends to be less tremor predominant and more bradykinetic or rigid predominant with a little bit of gait. The reason this is important is that they do not look like an Alzheimer patient. If you actually see these patients, they look Parkinsonian. They can't draw a clock. Even if their mini mental is 25, they cannot draw a clock at all. The clinical characterization using biomarkers, you could use FDG PET, you could use cardiac MIBG. I will tell you that cardiac MIBG, almost very few hospitals are doing them, if at all. You could do a DAT scan to look at dopamine uptake. You could do sleep studies to look for the RBD. So the most specific for the disease might be DAT and cardiac MIBG, whereas RBD is a symptomatic feature of Lewy body dementia, but is not necessarily diagnostic. Although some people think that RBD is a predictor of synucleinopathy and therefore could be considered for it.